Hello, and welcome to the second of our Key Opinion Leader webinars. Today we have Mr. Ian McDermott, who will be talking about how to handle knees in the current COVID crisis. Just wanted to introduce Mr. Ian McDermott. He's a specialist consultant knee surgeon at the London Sports Orthopaedics Group. He's a leader in his field and deals predominantly with complex knee problems for second opinions and revision work. His professional accolades include being the youngest ever surgeon to be elected as a council member and trustee for the Royal College of Surgeons. He's an honorary professor associate at the School of Sport and Education at Brunel University. He's founder and immediate past president of the UK Biological Knee Society, co-vice chairman of the Federation of Independent Practitioners Organisations, and his practice is designated as a centre of excellence for meniscal transplantation surgery, custom-made knee replacements, and also the use of biological glues in knee surgery. So before we start, I just wanted to go through some housekeeping rules, just to let you know about how you would communicate with us. In terms of the different ways that we have, you can type any questions that you have through the Q&A function. If a question doesn't get answered straight away, we'll try and come back to it at the end. If not, we'll actually send them through to Mr. McDermott afterwards, and as best he can, he'll respond to those. You can also use the chat function, so that allows you to discuss things both as a group and with us. This section will be recorded, and it will then be put on the Össur Academy YouTube channel, so do search on YouTube and you'll find the back catalogue of previous webinars on there. We'll also send you an e-certificate for you to go in your CPD file, and there'll also be a feedback form as well. So we really appreciate any feedback that you have about how we can change and how we can improve these sessions. So really, it just goes for me to pass over to Mr. Ian McDermott. I want to thank him for joining us today, and I hope this will be a really interesting talk.
Thank you very much, Giles. Can you see my screen?
Yes, we can see it. It's fine.
Perfect. Well, welcome everybody. Certainly welcome in very, very unusual and very difficult times, and I hope everybody's families are well and safe. First of all, I'm going to just, as a caveat, anything we discuss, please put it in the context of the current very unusual nightmare situation that we're all in. And just to repeat what everybody's heard a million times already, please follow the government guidance, which is only go out if you have to. And that applies to all of us as workers, even as key workers, and also applies to our patients as well. So stay at home to try and flatten the peak, to try and protect and minimize the possibility of overload of ITU services. So myself, Giles very kindly introduced me there, and yeah, I do nothing but knees, so that's all I can ever talk to you about, I'm afraid. And I work in a group practice called London Sports Orthopaedics, which is based in the middle of the City of London, and there's 15 of us consultants covering the whole of orthopaedics with different subspecialties, plus sports medicine, rheumatology and pain management. But really importantly, at a time like this, well, who really cares about something as trivial as knees? Well, it's a very simple answer to that, and that's people with knee problems. So even at the time of a pandemic, people still have problems with their knees. They're still going to suffer problems and knee pain. And if you're suffering a problem, then it's a very real problem to you as an individual. So we're seeing exercise-related injuries. Anybody who looks out their window now, on most days, will see a variety of people running along the road. Trying to be polite about it, it certainly looks as if a significant percentage of those people are not used to running, and it's a novelty for them, and they look not like your average runner. And if they just suddenly start trying to exercise without having been conditioned and building up to it, then there's a propensity for problems. On top of that, we're seeing an awful lot of people doing exercise classes online now, and that worries me enormously, because again, if you get over enthusiastic, if you're not under supervision, if you're not used to doing it, there's the risk of injury. And then we've got a different cohort of people who've got more chronic conditions, so pre-existing chronic conditions that would normally be treated, which are now gone on hold. So normal medical care has been mothballed across the entire country. And that's a major, major concern. So before we go any further, we'd like to do the first poll. And Giles, if I could ask you to put that up. And this is just to give us an idea about who our audience is today. Are you a consultant? Are you a non-consultant doctor, a physiotherapist, podiatrist, orthotist, prosthetist? Are you an osteopath? Are you a chiropractor? If you could please enter your information on the poll, which should hopefully have popped up on your screen.
Yeah, we've got about 80% have answered.
That's fantastic.
So I'll just stop that there and then share that with everybody.
Okay, lovely. So a couple of consultants, but predominantly physiotherapists and a significant number of others. So thank you, Giles, if you could. Right, a little bit of COVID pontification, perhaps, before we actually get stuck in. Very, very difficult for anybody to predict, very difficult to guess this, but it would seem that an estimate of approximately 24,000 deaths from COVID would not seem unreasonable at this time, which sounds like an absolutely horrific number, and clearly that's deeply upsetting on every single level. And without even ever wishing to trivialize it, which would be ridiculous or sound unduly callous, these numbers have to be put in context. There's no point in giving a numerator without defining the denominator. So 24,000, but we normally see 600,000 deaths per year in the UK, which was a real surprise when I saw that figure, but that's a large number. Well, if there are only 24,000 deaths from COVID, then that would only represent 4% of all deaths this year for all causes, which seems like a surprisingly small number. And balanced against that, we've got the lockdown, and nobody in their right mind would disagree that the lockdown was an absolutely sensible approach and justified. And it's all about flattening the peak to protect the NHS from being overloaded in ITU departments. And we understand that, but the real question is, how long will the lockdown carry on for? Just a few more weeks, or are we talking months, 3 months, 6 months? Nobody really knows. What will be really interesting will be retrospectively to see what the numbers from Sweden look like compared to other Northern European countries, to see whether their different approach yields higher or lower mortality figures. And epidemiologically, history will tell us, but at the moment, nobody really knows. What we do know is that if you are forced to go into a city centre, then things are eerily quiet at the moment. It's a very, very strange place to be in central London right now. But what people are only just beginning to wake up to and to start talking about is the potential iceberg that's ahead of us. Whilst we're all focusing on the number of potential deaths that we're expecting to see from COVID, what we mustn't do is forget that 96% of deaths this year will probably be from non-COVID related problems, and all elective, non-emergency, non-time critical medical care across the UK has pretty much stopped. People haven't stopped getting ill. Diseases haven't stopped progressing. People are simply in a holding pattern, and that means that we're not seeing people being reviewed, assessed, screened. So we're not picking up on people who've got cancer. There are people who have been diagnosed with cancer, whose treatment is now on hold, who've had their chemotherapy stopped, which is shocking. We've heard stories of plastic surgeons in central London being instructed to no longer undertake complex limb reconstructions for major limb trauma, because those are multi-hour procedures requiring multiple procedures, lots of hospital time and lots of hospital stays, simply being told now that the directive is amputate, don't reconstruct. So what we're doing is we're storing up an absolute tsunami of medical problems. And again, supposition, but if the overall morbidity and particularly the mortality rates from non-COVID diseases increases this year by as little as 10%, then that will see an overall 9.6% increase in the death rate compared to COVID, which may only cause 4%. So we may actually see twice as many deaths due to the lockdown compared to the number of deaths due to COVID. All supposition, and what this really means, it doesn't mean the lockdown is wrong. What it means is there's an incredibly difficult, delicate balance to be had between having the lockdown, but the main point is the tipping point as to when the lockdown needs to be stopped and routine services need to be restarted. And thankfully, that's not a decision that I or any of my colleagues will have to take, and I pity the epidemiologists and the government advisors who are in that difficult position. So, knees. People do not stop having knee problems at a time of crisis like this. They certainly stop worrying about it as much, but the knee problems are still out there. So I want to focus on just 4 specific things that for us are relative red flags, issues that are still of sufficient concern for us to have to act even during a time of a pandemic. Locked knee, septic knee, or the possibly septic knee, the acute knee injury, and the very severely painful arthritic knee. So we're going to start with the locked knee. And Giles, if we could do our second poll, please.
So the second poll is, how long do you leave a locked knee to see if it will unlock? Whether that's 6 weeks, up to a few days, or it shouldn't be left at all. So we've got about 20% who've responded to that. We'll just leave it up for a little while longer. We're up to 60%. Okay, so I'll stop there. We're up to about 80% there and share those results.
Okay, well, thank you for that. I think that's great. That means we don't need to do the talk, really, do we? Because it looks like 50% of people, so nearly a majority, are perfectly on track. So with a locked knee, I think the first thing that we've really got to do is we've got to define, what does a locked knee actually mean? So with a locked knee, what we're talking about is somebody who's typically a younger patient, not exclusively, but typically, and somebody whose knee was fairly either normal or fairly normal, and it did extend fully, but then something happened. There's an event, trauma, or an accidental twist, like in an awkward position during yoga, or sitting cross-legged on the floor and getting up. But something happens, and there's pain, and suddenly the knee won't extend fully. Well, that's a typical locked knee. Very important to differentiate that from a pseudo-locked knee, but that's very difficult. So by pseudo-locked, what we mean is that it looks as if the knee is locked, but actually if you give the patient an anaesthetic, and I'm not saying that you should give an anaesthetic as a diagnostic tool for this, but if a patient with an apparently locked knee has an anaesthetic and the knee straightens out, then that shows it wasn't locked. There's no mechanical block. It was a pseudo-locked knee due to pain inhibition, for example, with a recent ACL tear with a stump of torn ACL tissue sitting at the front of the knee. Even more importantly, is to differentiate between a locked knee and a fixed flexion. So a fixed flexion is something that develops slowly and gradually, normally, typically in an older patient. And this is somebody with an arthritic knee. So this patient, and there's on a very odd slide, I got it off Google, it's not one of mine. It kind of takes us back to the bad old days where patients were stripped off completely and photographed and then just blurred in what looks like not particularly private environments. So it is a very historical slide. But what it does show clearly is a patient with a slightly swollen right knee with a fixed varus and a fixed flexion. And that's completely different from a locked knee. These are older patients developing arthritis, developing progressive stiffness. So locked knee, younger person, something happens, previously normal knee suddenly won't extend and it's painful. So the first question is, well, what causes that? Very importantly, from my perspective, a locked knee is always a displaced locked bucket handle meniscal tear until proven otherwise. Yes, it might be loose bodies. Loose bodies more often tend to cause intermittent temporary locking, like a little stone getting caught in your shoe. And if it rattles around and you wiggle the knee and it pops out of the way, then you can extend. So it tends to be more intermittent, more temporary. But as far as I'm concerned, anybody who presents with a locked knee has got a displaced locked bucket handle meniscal tear until proven otherwise. And so the real question is, well, how do you prove otherwise? And this is a very, very simple answer. And the simple answer is MRI. If somebody presents to you with a locked knee, they need an MRI. Is it an emergency? Well, definition of an emergency means that the patient needs to be admitted then and there, and they're probably going to need to be taken to theatre that night, or within a 24-hour period. So no, it's not an emergency. It's not life or limb threatening, but it's definitely an urgent. So no, you shouldn't leave it weeks. You certainly shouldn't leave it months. This is something that needs to be treated within a few days, preferably. And the first step towards any treatment is getting a diagnosis. And you're not going to get a diagnosis without proper imaging. And it's almost frivolous and foolhardy to just put a telescope into the knee and see, and use the arthroscopy as your diagnostic tool, when you've got a zero risk, non-invasive tool that should be available at your fingertips in an urgent situation like this, and that's the MRI. So this is a displaced locked bucket handle meniscal tear, medial meniscus at the time of arthroscopy. What we've got here is the displaced fragment sitting as a block at the front of the knee, and there's the medial femoral condyle. Once the knee's been washed out, this is a little probe, and this is probing that bucket handle fragment, and that's the bucket handle fragment pushed back in place so it's reduced, and then this is the bucket handle fragment repaired. And we've got meniscal stitches going around the periphery, also underneath, which you can't see on the tibial undersurface. This little area here is where there was a tiny little radial tear in the inner free margin of the body portion of the meniscus that received just a very minimal trim and then smoothed off with a radio frequency probe, which is like a little welding tool. So why does this matter? Why is it important? Well, these are pressure map studies from one of the studies we did many years ago at Imperial College with Professor Andrew Amos. And this top picture shows a pressure paddle in the lateral compartment of a cadaveric knee loaded in a materials testing machine with the meniscus intact. So low contact pressures. Bottom picture shows what the situation when the lateral meniscus has been removed, and what you have is a much smaller contact surface area with much, much higher peak pressures. And if you think that the yield strength of articular cartilage is about 2.5 megapascals, then straight away you can see if you lose the meniscus, you're going to overload the articular cartilage, which means the articular cartilage will fail and you will get premature wear and tear and degeneration, eventually leading to arthritis. So what we're trying to avoid here is the significant risk of very premature post-traumatic secondary osteoarthritis in young people secondary to loss of a meniscus. And in a displaced locked bucket handle meniscal tear, normally the bucket handle fragment involves the vast majority or the large majority of the meniscal volume. So if you lose the bucket handle fragment, then you're going to lose the meniscus. If you do lose the meniscus, then this is probably the best paper in the literature for quantifying in a simplistic kind of way what the potential risk of subsequent arthritis is. And this is from Roos and Roos from the Journal of Rheumatology, 1998. And what they showed is that if you have a total meniscectomy, then the relative risk of arthritis is 14 at 21-year follow-up. Far easier just to simplify it a little bit and say, if you lose your meniscus, then the risk of arthritis roughly 20 years later is roughly 15 times higher. Now, if that doesn't sound scary enough, then to put it a different way, the risk goes up 1,500%, and all of a sudden it sounds a lot more significant. So that's why it's very important to catch a displaced locked bucket handle meniscal tear early, before that bucket handle fragment that's displaced gets macerated by the femoral condyle, and before it scars up, contracts, so that it won't actually reduce. If you can't reduce it back in place and then stitch it, you're not going to be able to repair it and salvage it. So, locked knee. It's a displaced locked bucket handle meniscal tear until proven otherwise. You need an MRI scan within days, not weeks. If confirmed, then you're going to need surgery within days, not weeks, to try and reduce and repair and salvage the meniscus if possible. And this is urgent or time critical, not an emergency, but it's still time critical. So if somebody presents to you with a locked knee, even during this COVID period, then please refer them to somebody who is able to deal with them appropriately, get an MRI scan within a few days, and operate within a few days if necessary. Easier said than done in this time where anybody who needs any surgery at this time, we need to ask permission of the local private hospital CEO, who then needs to ask permission of the hub lead for whichever NHS manager is leading the local contract. So now we're going to move on. We're going to move on to the possibly septic knee. And we've got our third poll. Giles, if you could go ahead with that, please.
So with this third poll, the question is regarding septic knee, and is giving antibiotics the correct treatment for an infected or septic knee? Yes, no, sometimes. So we have about 20% answered. It's going up swiftly. I'll just leave it up for another 10 or 15 seconds. We're up to about 70%. Okay, great. I'll just end that there and then share those results. So it's 38% yes, 11% no, and then 51% sometimes.
Okay, thanks, Giles. Let's not dissect that poll because it was obviously a very ambiguously worded question. So let's just get stuck straight into this. Somebody presents you with a red, hot, swollen, very painful knee, a very restricted range of motion, very painful to weight bear, and also the patient looks ill. They look pale, they're pallid, sweaty, uncomfortable, distracted, anxious. Well, somebody presents like that, then this is a septic arthritis, right, until proven otherwise. You have to be aware of the differential because it might be an attack of acute gout. And even if the patient has no history of previous gout, well, this may be their first ever presentation. Even if they're on allopurinol, allopurinol reduces the likelihood of further acute gout episodes. It doesn't eliminate it. Or it could be pseudo gout, which is instead of urate crystals, are calcium pyrophosphate crystals, and this tends to be in older patients. Or it might be an inflammatory arthropathy. It could be psoriatic arthropathy. It could be related to ankylosing spondylitis. It could be related to a flare-up of rheumatoid arthritis. Again, it may be the first time that somebody with an inflammatory arthropathy is presenting with an acutely inflamed joint that just happens to be their knee. Or it could be possibly bursitis. I'm going to put that in question marks because with bursitis, you tend to get a more focal, a more localized swelling at the front of the knee, either prepatellar or infrapatellar, as opposed to the whole joint itself. And it tends to be far less severe. So what is the correct treatment for a possibly infected knee? Well, this slide is not mine. This picture is not mine. It's off Google, and it kind of shows the point, but there's a few learning points on here for sure. So first of all, as a disclaimer, it's not mine. Don't criticize, please. Very interesting to see somebody having a needle put in their knee, lying on a couch with no paper, no Inco pad, nothing to protect the couch or to protect the patient from the couch. Second, very interesting to see the patient still, the doctor or whoever it is, still wearing a sleeve that's nicely rubbing against the front of the patient's knee. And third, to see a scarily small patch of skin covered with a little bit of betadine. So this is absolutely not how I would advocate doing this. I wouldn't do it in a normal clinic room. I would do it in a treatment room. I would make sure that I've got an experienced nurse with me. I would cover the whole of the knee copiously with antiseptic. I would have a sterile drape underneath. I would have a sterile drape over the top with a hole in it. And I certainly wouldn't be wearing a nice shirt with a sleeve and cufflinks. The point is, you have to get a sample. If you think the joint might be infected, then you need to aspirate the joint and you will see cloudy fluid. So it may not look exactly like pus, but it is nearly always cloudy. And you won't be able to get it all out because this is quite very often thick, viscous fluid. And there's a limit to how big a needle you can comfortably get into somebody's knee. But you have to get a sample before you start giving antibiotics. Otherwise, if you treat with antibiotics first and then get a sample, then your sample may not grow a bug because of the presence of the antibiotics, and it could give you a false negative. So number one, aspirate the joint. Then number two, if you have a high suspicion of a septic arthritis, then very quickly you want to wash out that joint. You do not want to treat them with oral antibiotics. It's not adequate just to give the patient IV antibiotics. If you've got a knee full of pus, you have to wash that knee out. So this is an arthroscopy of a knee with suspected septic arthritis, in an interesting case where the patient needed to go to theatre anyway because they'd fallen on a glass lamp and they had a massive laceration at the side of their knee, and they'd actually transected through pretty much the whole of their ITB. So they needed that open wound exploring, and there was glass in the wound. But at the same time, in between the injury happening and then presenting, which was just under a 24-hour period, the knee had swelled up enormously and becoming severely painful. So the worry was whether the foreign body, the glass, had actually penetrated the capsule and caused an infected joint. So whilst exploring the wound, removing the glass fragments, repairing the ITB, we also did an arthroscopy. So this is what the knee looked like after we'd been washing out for a while longer. And then this is what the knee looked like once we've been washing out for several minutes. So now we've got a much, much clearer picture. We can see the ACL, but what we can also see here is lots of little white chalky-like deposits. And as you stroke those deposits, you can see the chalky materials being released like clouds of white chalky stuff floating around inside the knee. So the fluid was sent for microscopy, no bugs. Sent for culture, which takes a few days, no growth. Microscopy showed up uric acid crystals. So this is birefringent crystals on polarized light microscopy, and it confirms that this is actually urate deposits, gouty tophi. So interestingly, this patient did not have a septic arthritis, but he had his first ever attack of acute gout inside a knee that was triggered possibly by the traumatic event. So his knee settled down very, very quickly once it had been washed out and simply treated with strong anti-inflammatories. If you leave a septic knee and if you don't treat it properly, if you don't wash out the joint, then all that's going to happen is that the infection within the joint will destroy the articular cartilage, and you will have a massively increased risk of developing post-traumatic osteoarthritis of the knee subsequent to that. So that's why it's so important to wash out a joint, obviously also to prevent the patient from becoming septic, developing septicemia. So a septic knee is definitely on our list of urgent, and I would actually put that from urgent up to emergency. So next, acute knee injury. Well, somebody hurts their knee and they go, I twisted my knee and it really hurts. And what do you think I've done? Well, the answer is I don't know, right? And I did nothing but knees. So my first thought is, well, what have you actually damaged? And now you're thinking anatomy. What structures are there in a knee that might get damaged? So with a sports knee injury, under normal circumstances, not during a period of crisis, but under normal circumstances, somebody twists their knee playing football, they've hurt themselves. Well, they have pain and they have swelling. And what do? Well, they go to A&E. The interesting thing about the normal A&E queues that people might expect to experience under normal circumstances is that that's not the case now. The queues are probably more akin to the way that people are queuing outside Tesco's, with at least 2 meters in between. And the interesting thing to note, if you observe the queues outside supermarkets, are that the older generation, who seem to be a little bit maybe more pragmatic, tend to have slightly smaller gaps between them compared to a lot of the younger people who, and I'm not going to call them the snowflake generation, but people who are slightly more worried, who tend to have bigger gaps. It's just an interesting observation. And the other interesting observation is what we're hearing from colleagues now is that the number of people attending A&E currently is drastically reduced by more than 50% compared to normal. People are keeping away. But anyway, if you go to an A&E department not under normal circumstances with a knee injury, what do? They take an X-ray. And then what do they tell the patient? Well, good news, there's no fracture. But what's the diagnosis that they're left with? Well, a soft tissue injury. Now, that tells me nothing. And if you put that into the context of if we were neurosurgeons and somebody had a head injury, so they've gone to A&E, somebody's taken an X-ray and they said, oh, it's all right, there's no skull fracture. So what is the diagnosis? Oh, don't worry, it's a soft tissue injury. I don't think many neurosurgeons would be particularly kind of happy with that diagnosis. And neither are we. You know, anybody who deals with MSK patients, soft tissue injury just means nothing. But what do A&E say to the patients? Well, it's just a soft tissue injury. If you're lucky, you might get crutches, possibly a knee brace, possibly some painkillers, possibly some anti-inflammatories, and you're told to go and see your GP. Well, this is where our first poll, Giles, really should have said, is anybody out there a GP? So I'll take a punt on possibly no GPs. It'd be very interesting if there are any GPs, then we're about to see the number go down by 1 or 2. If you go to your average GP has probably done 6 weeks of MSK training as a medical student, and some of that would have been in rheumatology and some in orthopedics. So they've got very little experience in MSK, and yet about 40% of the primary care workload is MSK, which is slightly worrying. So it's not uncommon. Caveat, there are some fantastic GPs out there. Certainly all the GPs who I know and who know me are brilliant. Okay, but there are a few GPs out there who will not really be particularly well equipped for managing MSK problems such as an acute knee injury. And again, they may just say, rest it, anti-inflammatories, time. Or if the patient is lucky, they'll actually send the patient to a local trusted physical therapist who will hopefully be able to take things further. So if we're talking about ACLs, for example, and let's just focus on this in particular. And how many ACL injuries have you seen where the tibia was pulled forwards and the ACL snapped? Well, that's extremely rare. It's nearly always a valgus and external rotation injury. And with that, what you have to always bear in mind is that these are nearly always multiple injuries. If you have a typical valgus and external rotation injury on a flexed knee with speed and momentum, the first thing that will go will be your MCL, and that's normally a partial tear. Then if you carry on twisting, the ACL may pop. You may feel the pop, the snap. Then, as you carry on with that valgus and external rotation, there's normally a lateral impaction injury. As it carries on twisting and grinding, you may have a meniscal tear. If it keeps on going, you may tear the posterolateral corner. And if it keeps on going even further and you tear the PCL, then you're talking about a dislocated knee. Now, for most of the people listening to this podcast, this webinar, thankfully, we will not be presented with a acute injury that's a dislocated knee in a normal clinic setting. That's because that's a very major injury. It's literally limb-threatening, 40% incidence of major neurovascular damage. And that's the kind of thing that goes by ambulance to an A and E department. So thankfully, we can exclude that from this argument. But the important thing is to remember that there's no such thing really as a genuinely isolated ACL injury, although many of those other things may settle down and heal up on their own with time, converting the initial injury with multiple elements into an isolated problem within about 6 weeks or so. So let's have poll number 4, please, Giles.
So this is what percentage of torn ACLs are likely to end up requiring surgery? Is it a third? Is it half? Is it 2/3? Or is it 40%? So we have about 20% have answered so far. Just get up a little bit higher, leave that for another 10 seconds. Okay, great. So we're up to about just short of 80% there. If I share those results, so 32% have said a third, 24% have said half, 28% have said 2/3, and 16% have said 40%.
Okay, fantastic. So let's go through this. Do all ACL tears need surgery? Well, very interestingly, when I was a kid just learning medicine and first having a look at orthopedics, and this is more than 20 years ago, 50, 40, 30, oh God, more than 30 years ago. The old-fashioned teaching was the rule of thirds. And the rule of thirds was, if you tear your ACL, well, a third of people will need surgery, a third won't, and a third might. And that's the rule of thirds. We learned that years ago, donkeys years ago. Well, it's very, very interesting. And it's turned out that that's approximately correct. And it's been backed up by the latest research. So just to throw a little bit of research at people, this is a really important, really useful study that I quote on a regular basis and discuss this with my patients. And this is from Frobel, it's a Scandinavian study. And what this team did is they took people with an acute ACL injury, and this is an isolated ACL injury, right? Understanding in context of what we've already discussed. So they took people, and 120 people, fresh ACL injury, and they randomized them into two groups. Half the people had an early ACL reconstruction, half were sent for rehab. In the group who were sent for rehab, half of them did well enough not to need an ACL reconstruction, but half of them didn't and ended up needing a delayed ACL reconstruction. Then they looked at the outcomes at 5-year follow-up, which is a good long outcome, of the people who had the delayed ACL surgery versus the early ACL surgery. And what they found was no difference in any of the outcome measures that they observed. So very, very important study. And there's two main conclusions. From this study, one can estimate that maybe as much as 50% of people with an ACL tear don't actually need an ACL or will not actually end up needing an ACL reconstruction. And number two, if they do, but it's delayed because they've attempted rehab, then there's no harm, no additional harm caused. So this study strongly advocates the concept of prehab. ACL injury, give it time to settle down, start a course of rehab. If the rehab is the cure, is it the actual treatment, in other words, they don't need surgery, then fantastic, job done. Even if it's not the treatment, then the preoperative rehab, the prehab, will put the patient in a better position to be able to cope with the operation and the post-op rehab afterwards. So either way, prehab is a good thing. And this is on the assumption that they don't have, for example, a severe meniscal tear or multiple ligament injury that means that you can't cope with the rehab. But life's not that simple. First of all, this is a relatively small study. So it's only 120 patients, 60 patients in each group. It's a very well conducted study, but this is a very small cohort of individuals. And for every yin, there's always a yang. And you can create any narrative you like by selectively quoting the research. So you've always got to look for a balanced opinion. And this is the opposite end of the spectrum in terms of opinions. And this is a very important study as well. And this is from Pincheski and the team in Sydney. Now, Pincheski is one of the biggest biggest ACL surgeons in the world. And this study was phenomenal, really. They looked back at over 5,000 ACL reconstructions. And their conclusions were that if you delay ACL surgery by 5 months or more, then the risk of you needing surgery for a meniscal tear, a medial meniscal tear, increases by a factor of 2. In other words, 200% more likely to end up needing surgery for a medial meniscal tear. If you delay the ACL reconstruction by 12 months or more, then the risk of you needing surgery for a medial meniscal tear goes up by a factor of 6. 600% more likely to need surgery for a medial meniscal tear, which is just a fairly shocking statistic. So very interesting study. And this is basically saying the absolute opposite of Frobel's study. Another really good study that's worth being aware of is by Everhart. And this was another large study of 600 patients. And what they showed that if you wait more than 8 weeks before doing an ACL reconstruction, then the chance of you developing a medial meniscal tear that needs surgery increases 230%, but also the likelihood of that tear then being repairable decreases by 50%. And if you delay your ACL surgery by as much as 5 months or more, then the risk of you presenting with a grade 3 to 4 outer bridge articular cartilage lesion, which is significant, increases by more than 300%. So very interesting here, we've got a range of opinions within the scientific literature. So if we have a look again at the rule of thirds, so a third of people do, a third of people don't, and a third of people might. Well, if we divide that middle third, the maybes, into roughly 50% yes, roughly 50% no, then all of a sudden we've got a line down the middle. And what we're saying is half of people do, half of people don't, which interestingly fits in exactly with the Froebel study. However, what about, there's two caveats. First of all, studies talk about populations, talk about cohorts. Well, I don't think any of us see a population or a cohort. We see people, we see individuals. And the individual person in front of you may be on the far left of the spectrum or the far right of the spectrum. So you always have to take these studies with a pinch of salt and be very, very wary that you're treating a person, not a population. The younger the patient is, the more likely it is they will need an ACL reconstruction, because conservative management of ACL injuries in young active people has been shown very, very clearly to give poorer results. If the patient is short, stocky, big muscles, and tends to do things in a straight line, then they're less likely to need surgery. If the patient is tall, female, longer limbed, smaller muscles, a big acute angle at the knee, who tends to drift into valgus when they kneel or squat, and somebody who plays netball, for example, somebody who does a lot of cutting, pivoting, twisting type maneuvers on their knee, then they're far more likely to end up needing ACL surgery. And remember, none of this takes into account the issue of what else might be damaged inside the knee that might also potentially need treatment or prevent somebody from doing well with rehab. So big caveat there. It's important to be aware of the research. It's important to take account of the research. It's important to share the research with your patients so that your patient can make a fully informed decision. And when people say to me, when do you do an ACL reconstruction? It's very, very simple. The answer is when somebody's torn their ACL, when somebody needs it, and when they want it. You can't operate on somebody who doesn't want surgery. That's called assault. Right? And you can't operate on somebody who doesn't need surgery. That's called criminal. So the patient is an individual who will tell you what their aspirations are, depending on their profession, their hobbies, their personality, multifactorial. So all of these research studies, all of these statistics will guide your decision-making, not dictate it. But what's the relevance of all this to right now in the middle of this COVID crisis? Well, all of a sudden things have become somewhat easier. Our rule of thirds has become 1/3 right now, no. Well, another third right now, no, and the other third, no. Does anybody need an isolated ACL reconstruction at a time in the middle of a pandemic? The answer is no. Unless, and again, there's always caveats, there's always exceptions to the rule, unless the patient has a locked knee. So if the patient has a locked knee, then it's even more important, as we've said, to get an MRI scan. And this is a 19-year-old girl. And what we can see here is a femoral avulsion of her ACL. That's a complete ACL tear. But what we can also see is a very large fragment, a bucket handle fragment of a displaced lock bucket handle tear of the medial meniscus, with the fragment sitting in the notch, and she's got a locked knee. So the reason that this becomes urgent is to deal with the meniscus, not because of the ACL, but there's a strong argument if you've got a displaced lock bucket handle meniscal tear in a young person to operate early, try and reduce and repair the meniscus, and at the same time, whilst you're in there, reconstruct the ACL to stabilize the knee to protect your meniscal repair. So, leading on to our last section, and this is the patient with a severely painful arthritic knee. There's a lot of people out there. I've now got 25 patients who were booked in for surgery, who have now all had their operations cancelled, who are now on a waiting list, waiting for major knee ops with absolutely no guarantee of when we might be able to resume routine elective surgery. And some of these patients have got severe symptoms. For example, one daughter has been emailing me because her mother is crying in pain and can't sleep at night because her knee is so painful. So can we have poll 5, please, Giles?
So this is there ever such thing as an urgent knee replacement? Yes, no, or sometimes? So we have about 20% have answered. Just give it another 10 seconds or so. We're already up to 70%. Okay, and we'll end it there. I'll just share that. So 27% answered yes, 17% answered no, and 56% answered sometimes.
Okay, I'm glad we did this one. I'm glad we saved it as the last poll. I think that's very, very interesting. Sometimes people are probably in some funny kind of way right, because there's always an exception to every rule. It'd be really hypocritical of me to say, to be didactic now, and I've been saying that throughout the whole talk about exceptions to rules. I can't think of, off the top of my head, of a particularly good reason to do a knee replacement right now. So my personal answer to that poll would have actually been a no, which would have put me with the minority group. Our knee replacement patients are, under normal circumstances, older people. And the older you are, the higher you are, the more at risk you are during this current COVID period. And it's been shown that if you were to be admitted into hospital during this COVID pandemic, and this is from figures from Wuhan and also from Italy, then there's a very high risk of you picking up COVID in hospital. And if you develop a COVID infection in the immediate post-operative period, then the mortality rate can be anything up to 20%. So this is one of the situations where I'd actually say, no, I don't think there's any justification at all, unless there's some extraordinary reason as to how anybody could be justified in doing a knee replacement on any patient, which is very much elective surgery at this time during the COVID pandemic. So what can you do? If you're not going to operate, if you've got all these people waiting, well, there are a few things that we can all do. And this is really important. Not operating doesn't mean we can't support them, we can't help them, because we can. So first of all, if you have somebody with medial or lateral unicompartmental arthritis, well, if you can offload the affected compartment or relieve some of the pressure, well, that will help relieve their symptoms. And that's with an offloader brace. So the brace that I recommend is the new Össur brace, which is the Össur Unloader 1X, which is more ergonomic and very effective. And if you look at unloader braces, they can offload the affected compartment by as much as 13%. Now, 13% doesn't sound like much, but if you put that into the context of somebody who's a bit old, fat, bald, 6 foot tall, who weighs about 100 kilograms, like me, then if I was to offload one compartment of my knee by 13%, that would be 13 kilograms. And if you can imagine carrying around a 13 kilogram dumbbell all day long, that's absolutely enormous. So it does actually make a big difference in terms of reducing symptoms. And there's very good studies out there that show that unloader braces, when used for the right patient at the right time, and it's the right brace fitted correctly and actually worn, if the patient doesn't comply, a brace sitting in a cupboard does nothing. But under the right circumstances, the brace can reduce pain, it can improve people's function. If you improve their function, they can maintain their fitness levels and strength levels better and keep their endorphin levels up, which is positive on many different aspects, including pain relief. And it can delay the time when surgery becomes necessary. So it's a fantastic stopgap. And it can be an alternative so that some people may actually choose not to go ahead with surgery at all. So I would strongly recommend the use of an offloader or an unloader brace for somebody who has got medial or lateral unicompartmental arthritis. Obviously, it won't help somebody who's got tricompartmental arthritis, and this kind of brace won't help somebody who's got patellofemoral arthritis. So what about steroids? Well, this is a little bit contentious now, and the latest guidance, which has been endorsed by the British Orthopaedic Association and its NHS guidance as well, is that we've got to be very, very careful because of the potential concerns of the effect of steroid in increasing morbidity or even mortality in people who may have COVID. So the guidelines say you shouldn't stop current steroid use, but taper their dose if possible, and it's safe to do so. Think before starting steroids in the current pandemic, and that's think very carefully. Use the lowest possible dose of oral steroids and only give steroid injections if the patient has a significant disease activity and there's no alternatives. So what that means is, again, a caveat. It is within the current regulations. You are allowed to give steroid injections into a knee, but you've got to be very, very wary of it, and you've got to be very aware of the risks and only consider this if really absolutely necessary. So under normal circumstances, right now, the answer is no, don't do it, avoid it. And that then begs the question, well, what can we actually do? Well, there's quite a lot we can do. We can still assess people. And most of us are now doing Zoom or Skype or Microsoft Teams meetings. And these meetings, they're not the same. Of course, you can't engage with the patient, you can't get as good a history, you can't develop a rapport, you're not going to get the same interaction with the patient. You can't do a full clinical examination, but many of us are learning the skill of describing to the patient what maneuvers to do, point where it hurts, stand up, straighten. You can certainly do a remote clinical examination, obviously not a full one, but it gives you a lot more information than just an email. So there is still value. And what it can also do is it can help flag up those urgent cases, those cases that do still need to be referred. Now, very fortunately, we are still able to see emergency cases and time critical cases. And depending on who you are and where you're working in terms of your geography and what setup you've got, some of us are in a lucky position where we can actually still see patients face to face where necessary. The default is remote consultation where possible. In those cases where it's not possible, or it's not practical, or there's something where you've got some concern, then luckily in our practice at least, we're still able to see people face to face. I'm not sure how widely that applies in other practices, other geographies, but you still have the ability, when you're seeing a patient, to refer them if you think or if you suspect that there's an urgent problem, and that's important. So what can we actually do? Well, just talking to people, keeping them going, psychological support, reassurance, it goes a long, long way. Educating people, taking away the fear and the uncertainty, but also rehab and exercise advice. Helping people remotely is better than not helping them at all. And then finally, we're lucky that we've got access to pain specialists. So in our practice, we've actually got a pain specialist, Ben Huntley, who's fantastic. Well, if you've got somebody who has got a complex problem and you need better pain management, like a stronger prescription than just paracetamol, Nurofen, well, who better than a pain specialist? And they still got the ability to prescribe. So that's still a very valuable resource that we shouldn't forget. So when you look out your window and when you see people jogging who don't look like that, but they look more like me, they got a belly and they may be wearing, leg warmers and even a sweatband around their forehead because the last time they ran, that was actually fashionable. That's a major concern. When we've got people doing exercise classes at home, yeah, it's brilliant psychologically and it's brilliant if they don't hurt themselves, but it's a worry if they do. DIY. Everybody's now catching up on all those DIY projects that they've left for years and years. Very, very worrying for hand injuries, so very worrying for trauma. And this is a time of relative danger. So I very much hope I've got the sound turned off for this one, because if you can hear what she's saying, then I can only apologise if there's one or two rude words that you might overhear, but I think the sound's turned off. So I think it's beholden to all of us to warn people that this lockdown period is not a time to be frivolous, to be risky, to do things you've never done before. It's absolutely not a time for the kids to be jumping up and down on trampolines. A net around a trampoline is a good idea, but it doesn't stop kids from breaking their arms. And if you have any kind of injury right now that's bad enough for you to need to go to hospital, to A&E, then good luck, because services at this particular time are drastically reduced. And we've seen lots and lots of images of x-rays of fractures, for example, where under normal circumstances they'd be fixed surgically, where currently people are just having to put them in a cast and say, well, it'll heal probably, and if it does heal bent, then maybe we can deal with it and deal with your malunion and treat that at some point in the future. It's going to affect outcomes. Very, very importantly, please advise all of your patients and your families, please don't hurt yourself during the lockdown period. It's not safe. Other than that, keep calm. Most people will get through this. And something to bear in mind, and this is gradually becoming more apparent in people's psyches and in discussion forums and on newspaper articles, is that the lockdown is fine for reducing the impact of the peak of the COVID curve. But during this period, all we're doing is stacking up an absolute tsunami of other medical problems. And MSK is probably towards the bottom end of the spectrum, things like cancer being at the top. But when this lockdown period does eventually end, we're going to see an absolute tsunami of problems. So if there is anybody out there who is currently feels like they're twiddling their thumbs somewhat because they're not doing anywhere near as much as normal, then try and maximize the amount of rest that you get, because in however many weeks' time, it's likely that we're all going to be absolutely swamped, and it's going to take a long, long time for us to deal with the inevitable backlog that has developed. So thank you for listening. I hope you found that A, interesting, B, useful, particularly in context of the situation that we've all currently found ourselves in. I'd be delighted to answer whatever questions you might have. So thank you.
Brilliant. Thank you very much, Mr. McDermott. That was fascinating. We have got quite a few questions here. I'll try and go through these as we work our way through. Ian Morrison asked, does the grade of tear for ACL affect your treatment of it? So you mentioned about whether or not you would operate. Does that really at this stage have a bearing on it?
Yeah, absolutely. There is such thing. There's even nowadays, even on Twitter, I've seen arguments as to whether or not there's such thing as a partial ACL tear. Well, 100% guarantee you that absolutely is such thing as a partial tear. The problem is the word partial means almost nothing to me, because partial could be anything from 1% to 99%. But the more partial, in other words, the smaller the percentage tear, the more likely it is that the patient will do well with conservative management. So absolutely, yes, it's much better to have a partial tear than no tear, but it's far, far better to have no tear than a partial tear. And the fact that you've been diagnosed with a partial ACL tear does not mean that you won't necessarily have functional instability with pivoting and therefore potentially end up needing an ACL reconstruction.
Right. Okay. Thank you. And Ryan McLeod asks, is there a cut-off age for successful repair for a meniscal tear? Does it depend on the area of meniscus torn?
Sort of yes, but no, first one. And second one, kind of yes. So first of all, in terms of the location, the more peripheral the tear is, and the closer it is to the edge of the meniscus, the peripheral edge of the meniscus where the blood supply comes in, then yes, the more likely it is to be repairable, and that's called the red zone. Also, if you have a vertical tear, vertical peripheral tear around the periphery, those ones tend to be repairable, and that's what most bucket handle meniscal tears are. If you have a radial tear, they are rarely ever repairable, and certainly the radial portion in the white zone is never repairable. Most horizontal tears are not repairable, so the configuration of the tear does matter. But you've got to be really careful here, because the predictability of repairability from an MRI scan is really poor. So you can't confidently rely on your MRI scan to tell you whether a meniscal tear is going to be repairable or not. That's a decision that can only really be taken intraoperatively at the time of an arthroscopy, when you inspect and probe the meniscus and see whether the configuration and extent of the tear and the quality of the tissue, as to whether it's soft, ragged, degenerate, and that would be like trying to stitch wet tissue paper, be pointless, or whether it's good quality tissue and healthy. So that then leads back to the first part of the question in terms of the age cutoff. Now, the younger you are, number one, the more likely it is that your meniscal tissue will be in better condition, with a better blood supply as well. And so the more likely it will be repairable. But also, the younger you are, the more important it is that you retain your meniscus. Because if you lose your meniscus, the bigger the consequences in younger people who, A, are more active, and B, live longer. So the consequences last for that much longer. So is there an actual cutoff? No. I've done a meniscal repair in a 65-year-old because unexpectedly, and I wasn't expecting to do it, I was expecting it to be a meniscectomy, a partial meniscectomy, but I always consent my patients for all eventualities. So we went in, and this guy was a runner. He's very active. He's not your normal 65-year-old. He was very, very fit and active, and the inside of his knee looked looked pristine, almost certainly better than mine. And his meniscus was in very good condition. It wasn't soft, it wasn't ragged, it wasn't degenerate. And he had a peripheral tear, and we repaired it, and it healed. But that's the exception, not the norm.
Right. Okay. I've taken this through. I've responded to this one a few times, just with regards to it. So it's from Alice Judd, and it says, given the risk of post-traumatic osteoarthritis with an unstable ACL deficient knee, would you consider reconstructive surgery as urgent? And then she also goes on to say, based on the MRI scan for whether other intra-articular damage has occurred, that this needs the treatment.
Right. MRI is absolutely mandatory. Right? It's an invaluable tool. If somebody has an acute knee injury and you haven't done an MRI, then you don't know what they've injured. So MRI is important diagnostically, but also as a screening tool. If there's nothing there, such as a displaced locked bucket handle meniscal tear, and it's not a multiple ligament injury, and if we're talking about the isolated ACL injury, understanding that there's really no such thing, if you want to be pedantic about it. But let's say the only thing you've really done is your ACL, and the MCL doesn't really matter so much, because more than 95% of MCL injuries heal up absolutely fine with just time, rest, conservative management, and sometimes splinting. So in the very large proportion of relatively isolated ACL injuries, then there's no justification for an urgent ACL reconstruction, because it's not life-threatening, it's not limb-threatening, and all you have to do is, somebody's got a really wobbly knee, is put them in a knee brace. Simple as that. So I think the answer to that question is no. Unless there are extenuating circumstances because of other concomitant pathology, there is no good reason to do an urgent ACL reconstruction. There are three main reasons, I think, why urgent ACL reconstructions do sometimes get done. Number one, professional athletes. Right? If you've got somebody who's a professional footballer, then you know that they're almost certainly going to end up having a reconstruction. Well, time is critical because of the money element involved, and that's not something that I find comfortable or prefer to have anything to do with whatsoever. But some people call themselves elite sports surgeons, and they've got a different approach to life because of the finances involved in that arena, which I find very uncomfortable. In those circumstances, a professional footballer may well get their ACL done very quickly. The next instance, this is something that needs to be publicised, and the public needs to be more aware of this, is that percentage of people who are skiing abroad have an ACL injury, and at the bottom of the slope, they're taken to some little private hospital or private clinic in Austria, for example, and they're told that they've got an emergency problem and that they need their ACL reconstructing before they go home. And I think that's criminal. I think that's completely inappropriate. People need time to be informed and educated about what their injury is. They need time to read up on it, to ask lots of questions. And if they're not given that opportunity, then actually you can't give informed consent, and that which means it's completely inappropriate. And that's done for financial reasons by some extremely dodgy surgeons. And the third reason is, unfortunately, there are surgeons out there who will go, oh, that's a nasty knee, we've got to do X, Y, Z, and we've got to do that straight away. And that's why, if you are a physical therapist, the best thing you can do is get to know your local consultants and get to know who are the honest, decent human beings who will give you the most appropriate measured response that's in the best interest of the patient, not the best interest of the surgeon. And you only get to know that by getting to know your local surgeons, which unfortunately takes time.
Okay. Fantastic. Perhaps just one more question. There have been a number of people asking about sort of the effect of age on your intervention. So what are your thoughts with regards to menopausal women and ligament reconstructions versus rehab approach?
What's my opinion on menopausal women?
What are your thoughts? What effect would age have on your input, whether that's a reconstruction or conservative management?
Yeah, I think the older you are, the more likely it will be that conservative management is the appropriate choice. Again, it's not that clear cut, it's not that black and white. You get some older people who are still playing in an elite vets sport. But the older you are, number one, the less years you've got ahead of you of doing stuff, of pounding that knee. Number two, the lower the likelihood of your functional demand. All right. Number three, when you damage a joint and you're older, quite often your main problem is stiffness rather than wobbliness. And number four, the risk factors are probably higher in terms of comorbidities and the risks of surgery. And number five, you're going to struggle a lot more with the rehab. It's much harder to build muscle bulk when you've got lower hormone levels and you're older. So yeah, there's always the exception to the rule. And yeah, I've done an ACL reconstruction on a lovely lady from the Northamptonshire area about a year ago, I think it was, and she was 66 years old, I think she was, but that's because she's a ski instructor still, and she still skis, and she had a wobbly, unstable knee. So in those cases, you've got to be very, very careful with your fixation for the ACL reconstruction. But that's a technical orthopedic problem, because then you're dealing with women who have got much softer bone. And when you've got softer bone, the fixation is less robust. So if you are going to do an ACL reconstruction in an older female, then normally you would do supplementary fixation to make sure that your anchor at the top and your screw at the bottom are less likely to fail.
Okay, fantastic. I think that's probably enough questions for now. We have got a script of the questions that you've sent through. So Ian's agreed that we can actually send those through to him, and we'll do our best to answer those after the session. Just really remains to thank Mr. McDermott for his really interesting talk today. Certainly very interesting given the current situation. There's also other content from Mr. McDermott. We had a 2019 webinar, so that's available on YouTube as well. If you go to the Össur Academy channel, you can actually see the previous webinar that we did. Really, just remains to say thank you. We will be continuing with our Key Opinion Leader webinar series. We're aiming for them to be every Wednesday at approximately 2 p.m. And next week, we'll be having a talk from Mr. Neil Jain. He's a consultant shoulder and knee surgeon, and he's be talking about rotator cuff tears in lockdown. So a really interesting session. Thank you again for attending. We will a couple of people requested those references that we put in the chat, so if you need those, please email eventsne@ossur.com and we can send those through to you. Thank you again to Mr. McDermott. It's a fantastic session.